My name is April Schweitzer. I'm an attorney in Nixon's healthcare practice here in Chicago. And we're really thrilled today to kick off our NP Impact and Recovery Chicago edition. This is our series of virtual events, and we're starting them today in Chicago. The purpose of this series is really to connect with our clients, our friends, and our community in the greater Chicago area to help spur innovative thinking and engage with one another as we discuss the challenges, trends, and opportunities across various industries as we work towards recovery in a post-COVID world. For today's program, we're fortunate to have partnered with Kaufman Hall and are joined by leaders from a variety of healthcare providers. Today's discussion will explore how the healthcare industry has been impacted by COVID-19 and what we expect to see as we move forward. Before we launch into today's discussion, I'd like to introduce our panelists who are each going to tell you a little bit about their work in their own words instead of listening to me read. And so I'll ask Earl to come off of mute, and we'll start with Earl Barnes.
Hello, good afternoon, everyone. My name is Earl Barnes. I am the Chief Legal Officer for Amita Healthcare. We are based here in Illinois, and we've got 19 hospitals, and they're focused on primarily on acute care, but do an awful lot in the behavioral care side of the house. Our company is a joint operating company, and it's in part owned by Advent Health in Florida and Ascension Health in St. Louis. And so I've been with the organization for just over a year now, and excited to be part of this panel. So thank you.
Thanks, Earl. Dr. Hanlon, would you like to go next? Oh, you're on mute.
Can you hear me now?
We can.
Okay, sorry about that. I'm John Hanlon. I'm the president of OSF Little Company of Mary Medical Center in Evergreen Park, Illinois. Evergreen Park is a southwest suburb of Chicago, just on the city limits of Chicago. I've been on the medical staff here for 33 years. I've been the chief medical officer here, and I've been the CEO president for the last 2 years. We've had a particularly significant amount of COVID here over the last 3 to 4 months, so I'll be happy to discuss our experience here, and I'm grateful to be here on this webinar. Thank you.
Thanks so much. Nicole, do you want to go next?
Sure. Hey, I am Nicole Kazee. I am the Senior Vice President of Strategy and Business Development at Erie Family Health Centers. We are a network of federally qualified health centers in the Chicago area, which means we are primarily located in low-income communities and serve a patient population that is primarily Medicaid and insured. We are north and west sides of Chicago, and some. Happy to be here.
Thanks, and certainly last but not least, Gordy.
Good afternoon, everyone. My name is Gordy Sofianis. I'm a senior vice president with Kaufman Hall and Associates. For those who don't know Kaufman Hall, we're a management consulting firm. We provide a whole suite of management consulting services to almost exclusively not-for-profit providers. We have done a lot of work with organizations across the country, health systems, physician groups, you name it, and looking at what's happening to them and the impact of COVID. So looking forward to talking about what we've seen both locally in Chicago as well as across the country.
Great, thanks, Gordy. We look forward to your perspective. I think just to kick off the discussion, what I'd like to hear specifically from the provider representatives on the panel is to share some of just the biggest changes that you've seen or implemented within your respective organizations really since March, since COVID hit. And maybe Dr. Hanlon, since you kicked off in your introduction talking about the influx of COVID at Little Company, and it's gotten some press as well, we could start with you.
Okay, I am unmuted, correct?
We can hear you.
I'm having some technical difficulties, so you'll have to unmute me when you talk to me. As I stated before, we did have a significant amount of COVID here. At one point, 90% of our inpatient census was either COVID confirmed or PUI. We've had over 1,000 patients that we've treated on an inpatient basis as either confirmed COVIDs or PUI. So that doesn't count our outpatient as well. For a while, we had about 4 times the usual number of patients on ventilators that we usually do. So we had a significant stress to our system during that time. One of the main challenges we had then was really staffing. We also had challenges with getting a number of ventilators here. We never quite got to the situation they had in Northern Italy or even in New York for a short time, where there was a question of allocation of ventilators and some of the other resources, but we got pretty close. So it was a significant challenge, both from a resource standpoint and from a human resource standpoint. We were fortunate enough, since we'd actually just gone through a merger with OSF on February 1st, that we had access to staff from the ministry level, from the OSF ministry level. So we actually had 100 employees from OSF come and help us at any particular point during the crisis.
Great. Earl, do you want to pick up on the biggest changes that you've seen at your organization since March?
Well, and I'll talk a little bit about perspective from the legal department side, but also happy to talk on a little bit about the clinical side. But I know for us, suddenly telling all of our folks, and we were one of the first systems, I think, that actually had a COVID patient. So in some respects, that was a benefit to people like me, because seeing what was coming, it gave me a little bit of an opportunity to start to plan. So we were able to, I became the designee in my department, at least, for keeping track of all of the regulatory changes and the various waivers that were coming out of the federal government and the state government, and quite frankly here, even in the city of Chicago. And that allowed me to really start to deploy my team in a way that made sense for what was going on. And what was going on is literally daily. There were questions about what we could do and what we could not do. Telehealth, which I know everyone will talk about at some point, became a very big issue for us, because very early on, it was apparent that we needed to start doing those telehealth visits. And, we had some capacity for it, but certainly didn't have capacity, at the level that we needed to be able to service all of our patients. So a lot of reassigning within my department in terms of telling people that these are your areas now. And, and quite frankly, in part, your responsibility is to start to reach out to the clinical side of the house and make sure that they have the support that they need on the legal side. And generally, I think we were successful with that. I mean, there's some things that, you make a little list of all the things that you want to work on going forward. But a great team, and they all responded very, very well. I think within the system, from the clinical side, we pretty early on established a team that was responsible for monitoring the total number of COVID cases that were within the system, the total number of suspected COVID cases that were in the system. And we began pretty early on coordination to assure that the care was consistent throughout all of our facilities.
So that was the hospital and sort of the system perspective. Nicole, could you weigh in from primary care FQHC perspective? What changes needed to be implemented in March going forward? What are the biggest changes that Erie has implemented?
Yeah, we found ourselves simultaneously having to meet the COVID-related needs of our patients and safely continue our usual business, because like all healthcare providers, we're still helping women who are going to have babies that don't seem to know that COVID-19 is here and that it's not a good time. The work continues. And so we, like everyone else, made a dramatic pivot to telehealth. Went from doing a handful of telepsychiatry visits and didn't do more, largely because of limitations and reimbursement policies, to about 60% of our visits are done virtually. And that change happened very, very quickly. We reworked our sites. So some were sort of fever clinics and others were well sites, meaning that patients who had symptoms, or even if they were there for a prenatal visit, if they had a cough, they went to a fever clinic, and everyone else went to a well site. I think what that helped us do is kind of see our sites as more flexible than we realized, that we had been set in this. We have 13 locations, and some of them were specific to certain things. most of them, we do all full service primary care, but have started to really think differently about how we use our space and what really the right way to use that space is. Once telehealth had stabilized and we felt like we could serve our patients well, we had appointment availability again, we launched a major outreach effort with two areas of focus. One was around targeting our high-risk patients, for example, diabetics who had not been in clinic, to let them know they can still get care. We also have done a lot of work around reaching out to our patients with known social determinants of health that will cause barriers. So we scrubbed our EMR and found, we have now reached out to something like 12,000 patients who we know of some sort of challenge and have many of them to services. The last thing I'll say is about testing. We, of course, are doing a lot of testing, and I think what we learned very quickly is that testing in a vacuum becomes problematic, especially when you're talking about a population that often doesn't have access to information about how what they're supposed to do, doesn't have their own separate bathroom in their house where they can quarantine, and is struggling with all sorts of other coping barriers. So this is where our role as a healthcare home we found became really valuable, because making sure when a patient came in for a COVID test, they were also getting all the public health information they needed, whatever language they needed, assessing their behavioral health and making sure they got what they needed, connecting them to employment services, to you name it, and maybe they also would need their asthma to be managed. So this really became a lot of our role, is how do we integrate COVID care with the larger role of being a primary care health home.
Yeah, I want to put a pin in the space discussion, because that has come up with a number of clients and providers, especially primary care providers that we work with and that I've been talking to and thinking about how do we use space. And I'm sure healthcare providers are not the only people who are thinking about space right now, but I would like to come back to that topic. But Gordy, to round out this opening question, could you talk a little bit about what you're seeing providers do to survive in this environment, or what steps you all are working with providers to take what you think needs to be done in order to survive, especially if we have some reports say we're not out of the first wave yet. Some people are talking about a second wave, but regardless, we're talking about phase 4 here in Illinois, but we're still seeing COVID patients. So I don't think we're out completely yet.
Yeah, April, I'm happy to provide a macro perspective here, I think, from what we've seen. And it may have a little bit more of a financial tint to it, but I think that's a lot of the challenges that providers are faced with right now. And we've kind of viewed it in a couple stages of impact, and it's a little bit different from the phases that we're talking about at kind of the state level. But what you had initially was this preparedness or surge stage, we'll say, whether you were in a hot spot or not as providers. And that really happened in kind of the middle part of March through April, where we saw a significant disruption to organizations in terms of volumes and revenue down, in a lot of instances around 40 to 50% of lost volume, as elective procedures were shut down from a regulatory perspective, as people self-selected not to go to emergency departments or other urgent care or ambulatory settings for care. And as a result of that, in April, we saw median hospital operating income margins at about negative 29%, which is the lowest we've ever seen that, and it's a significant drop. And as a result of that, we saw rapid development of federal funding to help aid providers in the form of CARES Act. And those distributions that have gone out in April, May, and June now, some of it a bit more targeted than the general distributions. We also saw Medicare advance payments be pushed out to providers, and a lot of organizations have tapped into that to shore up liquidity, which was really one of the big concerns. As you saw the revenue stream drop and profitability drop, how are we going to protect ourselves if we didn't have a very strong balance sheet? So a lot of organizations in April were getting their ducks in a row around that, accessing the federal funding, looking to see where they could potentially drive improvement or kind of reduce costs, although some organizations have elected not to do that. And then we've certainly seen, organizations tapping into lines of credit and their banking relationships to help shore up liquidity as well, which is really the big concern. I think right now we're starting to head into this post-surge kind of recovery stage until we might see another, big COVID surge, right, which could be out there in the fall. So organizations are certainly, tapping into increased use of telehealth. We're seeing elective procedures come back and organizations figuring out how they can actually manage delivery of those procedures while still having actually, in some instances, more COVID patients in-house now than they did back in March and April when things were initially shut down. So I think the response can be a bit more nuanced moving forward in that respect, in that organizations can figure out how to manage COVID while also still continuing their business. We're seeing a lot of FEMA and other federal funding applications go out and organizations tapping into that. And then a lot of scenario planning just around, well, what is the recovery going to look like? We might get to 100% of our volume back at some point, but it might only represent 90% of the revenue, given changes in payer mix and bad debt and charity care. And so organizations are going through those exercises and thinking about, well, what happens if there's a secondary surge? How are we going to respond to that, and how are we going to help mitigate the financial impacts of that?
Gordy, I want to pick up to move to the next topic. I want to talk about, you talked about elective procedures and patients coming back, and I think there were certainly some reports of patients' fears and not going to the ER, and certainly providers took a hit when elective procedures were canceled. Maybe Dr. Hanlon, could you talk about, are you seeing patients come back at this point to elective procedures, or what are you seeing as far as people coming back to the hospital, really?
Sure. Well, Nicole mentioned that, the sort of rapid move to televisits, and like every other system, we adopted that pretty quickly. And we will see a significant portion of that going forward, but we're finding a lot of our older patients still really want to have face-to-face visits. Just over the last 2 weeks, we are seeing an increase in the willingness of our patients to come in face-to-face. And just over the last week and a half, we're seeing a big increase in our elective surgeries. So we're pushing that. We are stressing with people the importance of cleanliness and spacing. Some of the other changes that occurred when COVID hit us in March, we do plan on carrying forward. Now, the financial losses Gordy talked about have been significant. There's been some job elimination, but not a lot, at least on our campus, just because we were so hard hit by the virus. We are seeing that the systems that had more risk contracts did better financially over the first quarter. And those premium dollars were there, and there was just a lot of decreased care delivered. So the systems with significantly more risk contracts did better financially. What we've seen is a lot of actual infrastructure changes that are really going to impact how we give care going forward. We actually were in the middle of a ED transformation project to increase our ED by 40%. We were through with the first of 3 phases, and what we did was we paused after phase 1, and we're actually changing the design, making all of the rooms negative air, changing the entrance and the triage area so that if another pandemic hits, we'll have a little better way of separating out our infectious disease patients and our other patients. And we're also seeing that the change in how we provide care post-COVID is really going to involve much more care at home. There's going to be much more digital care, much more just bringing care to the patients, particularly patients in this area where there's a real sort of a difference in the amount of care that's given to the patients in the southwest side of Chicago, or not so much given to them, but the severity of the hit of COVID to the African American population and the Hispanic population in particular. We need to address that. And so we've just recently have spoken with the University of Illinois with their innovation group about developing a thoughtful approach to addressing the inequities in the healthcare delivery that resulted in such a bad outcome for the African American community in particular on the southwest side.
Yeah, I think there's lots of initiatives for health equity, which is good to see. And Nicole, you talked about social determinants, and I think I think, reaching out to the number of patients and making sure that they're getting, the wraparound services that they need obviously can improve the health outcomes. And one of the conversations, and we can talk about telehealth maybe next, but one of the conversations that's been interesting as I've talked with patients about telehealth is how do we think about what patients really can effectively be served via telehealth, and behavioral health is an easy one, I think, to do via telehealth, but there are some questions about, who can really be effectively served via telehealth and who really maybe needs the in-person care. I don't know if anybody has any thoughts on that or has discussions about policies or protocols about either telehealth that you've implemented for COVID or what you think, how is it going to be utilized moving forward, and what are the challenges you've seen with telehealth? Any thoughts, Nicole? Maybe on the spot?
Sure. Yeah, sure. So I think a few things. I mean, I mentioned that having to rethink our clinic space gave us kind of permission to think differently about a lot of things. And the same thing has happened with telehealth. An example is prenatal care. We deliver close to 3,000 babies a year, and we started to realize that maybe not all of those prenatal visits in person. Some of them do, no question, but not all of them do. And so we've kind of developed a new model around how do we manage a pregnancy, and how often does a pregnant woman have to use public transportation or take time off work when she doesn't have paid time off, all those things to actually come into the clinic. We also think there's a certain mix, I don't know what that is, maybe a third of adult care that can be done well remotely, especially if patients have the tools they need at home. And how can we send packages of things to our patients to make sure that they do have what they need to monitor their health and not require time. I think as we talked about what are the challenges, I mean, if we look at planning for the next year, the single biggest factor that will determine our financial health in the next year is whether Medicaid continues to reimburse telehealth according to the new rules, or how far back do they pull it. For example, many of our patients don't have good access to video. They need broadband that they don't have. They need data packages they don't have. They need technology they don't have. And so we do a lot of our telehealth video, and have found the take-up rate is very high. It's actually been much more successful than we expected. And we've learned a lot about what we can do that way. But we have to be able to get paid for those visits. And that's one of those changes that it's an emergency change right now. Whether or not that continues post-pandemic will really determine our financial future.
Earl, any thoughts about telehealth?
Well, I mean, I think we're in the same position that many are in terms of wanting to expand and continue to expand where appropriate, and then making sure that we've got the right technology platform to do that on. And I think, in our particular system, and we've got multiple platforms that we've been using, and I think the goal, quite frankly, would be to try and move to one that will be fairly consistent. And figuring out how to make sure that those visits, how do you treat those visits? Are you recording them? Are you, how are you getting the information from those visits into your medical record so that they're memorialized appropriately? And of course, you want to be paid for the visit. So yes, we're spending a lot of time talking about it. I think from the legal and compliance side, one of my biggest concerns is making sure that we're following the rules. And so, I know pretty early on, I know people aren't all that happy with me, but I sent my compliance officer over to have some discussions around, what are the protocols that we have in place around the delivery of telehealth, and, how are we recording these visits? And, we are going to be keeping a very close eye on what's actually billed. Again, you don't want to find yourself in a situation in which down the road the government has an excuse to pull this. So, the goal is let's all try and make sure that we follow the rules, and we find ourselves in a good position when there's a look back on how well this is performed as a means for providing care.
Yeah. Gordy, any thoughts from you about telehealth or what you're seeing?
Took me a second to get unmuted there. I think it's all been very well said. I think this, at the end of the day, COVID has really been one of those agent for change events. in terms of, not only forcing kind of consumers to think about how they access healthcare a bit differently or how they might want to access it differently, but also the physician side of things. I think physicians, who were kind of reluctant to embrace virtual or telehealth care have done so, which has been good to see. I think, there will be lasting change as a result of this. And so as you think about, kind of care delivery and where you're going to make investments, as John alluded to earlier, stopping some work on the ED expansion project, it might be that a lot of ED visits don't come back. That's actually been one area where we've seen, a lot of volume has not returned, which makes you think around whether or not, the volume needed to be there in the first place. So I think we will see a lot of shift from that perspective, shift from, more low acuity inpatient procedures to outpatient, and then, outpatient surgical procedures being more of that done in an ASC type setting or other alternative settings. So I think it's here to stay.
I want to switch gears a little bit. We're talking a little bit about the future, and we talked about telehealth and talked about just the ERs. And I want to hear a little bit about, what maybe were some strategic priorities or your things that were worrying you heading into 2020, and sort of where do those stand now, or when might they come back? I think, healthcare organizations and other industries too, I think have been in, survival mode, changing very fast to accommodate surge and COVID. And I think it's a balancing act, right? To when to get back to quote unquote normal, or whatever that new normal might be. And so I think it'd be helpful to hear from folks on the front lines about, what did you think 2020 was going to be like, and how do we sort of come out of COVID and refocus or rebalance the scales and the priorities going forward? So, Earl, it's a big question, but maybe we'll start with you, both from a legal perspective, but also as part of the C-suite.
I think at the end of the day, I would characterize what's gone on here at AMITA as, we are delaying some things, but a lot of the plans that we have in place strategically, in this market remain in place. There's going to need to be heavy capital investment in the market, and I think that both of our sponsors have been fully aware of that from day one. And I think those plans are still on track, and again, maybe slightly delayed, but they're still on track. I do think that there truly is something to evaluating how, whether we've got it right in terms of how best to provide care going forward. And I know that we're going to continue to study that. But I think in many cases, a lot of institutions have worked on shoring up, their brick and mortar in terms of their actual hospitals and making sure that they're in good shape. A lot of movement has occurred to the outpatient side, and so I think with us and as with other institutions, that's going to continue, and so you're going to continue to see the investment there. I do think, obviously, on the technology side, there's going to need to be some decisions about what happens and where you're going to spend your dollars. I mean, at the end of the day, everyone does have a finite source of money to spend, but I think that for institutions like ours, a lot of focus is going to be spent on the EMR and making sure that we are able to find ourselves on a single, or certainly no more than two vendor platform. We think that that's a better way to provide good care to our patients. So, a lot of discussion around how to make all of that fit together. And for us, AMITA being relatively new in the marketplace as AMITA, that's going to be the way at the end of the day that we're able to continue to work to establish our identity, is finding a way to kind of brand ourselves as one versus multiple entities.
Dr. Hanley, you don't know anything about EMRs.
So, Little Company of Mary merged with OSF Healthcare on February 1st of this year. So at 12:01 a.m. on February 1st, they flipped the switch on Epic and we went live. And that was a lot of fun, and it was busy. And 4 weeks after that, COVID hit. And as you can imagine, the OSF Healthcare, had developed a nice strategic plan for the area. We are their first entry into the Metro Chicago area. So it's sort of an aggressive plan for strategic growth of both bricks and mortar and service lines. And I think the experience is the same as Earl has at Amita. Things are sort of put on hold. There was planned for sort of aggressive urgent care centers. There's still plans there, just not quite as rapid. I think things have been pushed back, the timeline probably about a year comparatively. But again, that's really going to depend on what happens with COVID in the fall. I think if our institutions get really hammered with cases in the fall, like we were in April and May of this year, that may cause us to rethink that. But even now, we are starting to look at service line growth, and we're starting to get back into sort of effectuating our strategic plan. But it definitely has put a wrench in the works. On the south and southwest side here, there are not a lot of hospitals, and Metro South, which is 4 miles away, closed last year. And there are other hospitals really fairly close to us that are in trouble. And there was the 4-hospital consortium on the south side that just failed recently, the proposed consortium. So I think the capacity of hospitals to take care of people in here is not strained, but it is certainly stressed. And I think that what our strategic plan looks like will really depend on how much our resources get tied up over the next 6 months.
Nicole, how about where did you think you were going in 2020 and where do you think you're going now for the second half of 2020?
We had so much clarity going into the year. I think it's one of those years, some years you just have a much better sense of what you're going to do that year than others. And we're very focused on 2 big projects, actually leading to FY21, which for us starts July 1. One was opening new sites, and the second was switching EMRs. And a pandemic like this, of course, has made us radically rethink everything. We actually did take a step back and look at, we're entering year 3 of our strategic plan. Really, how do we need to actually update our strategic plan to make it relevant to what's happening now? And the 2 big things that we have reshaped the strategic plan in some ways are safety, as we found safety is guiding so many of our decisions right now, and health equity, which is our core business as an FQHC in many ways, but we really need to double down on that and be explicit about how it's driving our decisions. I think the EMR question is certainly delayed. I think it requires a fair bit of capital to make that happen, and we kind of have to see how things play out here. But I think the health equity piece makes us more committed than ever to opening new sites, expanding in communities that we have seen get hit very hard by COVID, and to standing behind recent open commitments we've made around racial justice and how can we do something. And so I think we are figuring out, maybe, is there a new path to getting there? Because it may not be the path we thought it was 3 months ago, but I think we're committed to figuring out what that.
Gordy, can you talk from a macro level, sort of the trends, certainly that we're anticipating in 2020, and how providers specifically you think are pivoting, and what you think we're going to see in the second half of 2020 leading into 2021. And maybe this leads into one of the topics that was on my list was consolidation. So if you want to lead into that, Gordy, feel free to comment on that too, and we can get others' takes on. Certainly I'm not asking you to comment on your own organization, but in the market and certainly physician practices, what do we think we're going to see as a result?
Yeah, I think, April, there's probably 3 buckets of providers out there right now, just as we think about strategy, and Earl and John really commented on the first bucket, which was, hey, our strategy still makes a lot of sense, but we've got to pause or delay it for just a little while as we kind of recover from COVID and see where we are coming out of this. There's probably another bucket of providers who are looking at their strategic plan and saying, well, do we need to put a different lens to this? So as we recognize all that's happened through COVID and where we see the landscape heading, are there certain things that within our strategic plan still make a lot of sense that we're going to still pursue those? There might be some things in there that we're going to deprioritize or might fall off. And then saying, well, what are the gaps that we have and what do we need to kind of reset in terms of strategy? That could be things around plans for telehealth or virtual care. We're 3 to 4 years down the line and now we're accelerating those. It could be that, hey, we've got wholesale gaps in our delivery, care delivery system, and we've got to be able to kind of shift our capital priorities to help plug those gaps. So I think people are looking at all of that. And then I think there's a third bucket of providers who are saying, yeah, our strategy still makes sense. And we feel really good about our financial capability right now and coming out of this. We're going to be more aggressive coming out of this. And I think, April, that leads to your question about consolidation. And I think we will see more of that. I think there's a couple themes that we see coming out of this. There's the delivery system transformation that we talked about and providers kind of reorganizing themselves in light of COVID and consumer expectations around accessing healthcare. I think there's going to be increased physician group, consolidation or partnership with healthcare systems or health plans potentially. And then I think you'll see smaller healthcare systems or those without, sufficient financial capability and strength, seek partners to access additional scale and the financial resources moving forward. So I think the theme of scale will continue to, advance in the latter half of 2020 and into 2021. I mean, we saw the recent announcement of Beaumont and Advocate Aurora, two already very large systems looking to come together. So I think we'll continue to see consolidation, and that'll be not only amongst providers, but also the physician side of things.
Yeah. So can I say a little bit about that as well? Uh-oh. I think what we're finding is that the consolidation piece, it's been there and it's always been there. I think we're less focused on that piece at this point. A lot more focused on maybe collaborative opportunities within the marketplace. And I think I will say this: I do think that many, you have to ask yourself at the end of the day, what are the true benefits from some of these, mega collaborations? I mean, what's the real benefit to the community and to the patient base? And if you can make a case for it, I think it makes a lot of sense. But I think that when you look back at some of the deals that have been done over the past few years, one could question, well, what's really come from that? And we've got AMITA, and I think we've got a lot to prove in terms of what we're trying to achieve with our 19 hospitals. And I think at this point, we're comfortable that we should stay at around that size, figure out how to deliver good care within this market, and not be as focused on some of the other markets that are out there. So it'll be interesting. And I do think there's going to be some wonderful opportunities to collaborate with other institutions and some recognition maybe that there's some service lines in some areas that institutions are very strong at, and other areas that we're not as strong at. And so why not look for opportunities to collaborate there? So that's where we sit.
Nicole or Dr. Hanlon, any thoughts about consolidation or any other thoughts about, where we're headed?
I agree with Earl on that. I think that well, first of all, a standalone hospital, as we were prior to February 1st, just can't make it, particularly in a crisis like we had. If we had not been affiliated with OSF Healthcare, we would have been in deep trouble. You're subject to supply chain disruptions. We all know about what happened with PPE, but there were things like ventilators and even people, staff absences. If we had not been part of a system that could spare 100 people for us, we would have been in big trouble. So I think consolidation is definitely going to continue. How big do systems need to get? I think 2 is too small and 100 is too many. I don't know what the right number is in between, but I think there is some economies of scale that come with that and some contracting abilities. I think the South Side will show significantly more consolidation. These hospitals have been severely stressed by this. Some of them are still standalone hospitals, basically, although many are safety net hospitals. But I think that consolidation will continue, but I think at a point when they get very big, there was one system that I read last year had 8 different EMRs in their system. I don't really think you're a system if you can't communicate with each other. So I think there is a point where you're big for big's sake and it doesn't help.
I want to circle back, Nicole, if I could pick on you about the space question that you brought up, the facility question, and just ask you to comment a little bit more about how you're broadening your thinking and the flexibility about space. And is it just, you know, we've seen some systems designate specific hospitals as specialty hospitals, but how are you thinking about space? Is it just moving practitioners around, or is it really thinking about using specific space for specific purposes? Or what are the kinds of ideas that you're really thinking about when you talk about, you know, we've seen that we can think about space in a more flexible way?
Sure. So I guess there are 2 ways to think about it. One is the clinical services, and the other is the administrative staff, and how we're going to think about changes to both of those. On the clinical side, of course, it does involve the continuation of a fair bit of telehealth, because we don't have our ratios of providers to exam rooms will change, and so we just will not have the space for everyone, and so some people are going to be home doing telehealth. But I think we've also thought about, okay, well, so at site X, is this the right site to be doing adult care? Really come down to it. Or is there another site that's close to this community where we could shift our adult care model? And because our providers have had to face a lot of uncertainty and moving around a lot, there is some expectation of constant change, and it's our moment probably to kind of rationalize some of that. I think on the administrative side, you know, we have about 250 staff who pivoted to working full-time remotely during the pandemic, and are now kind of figuring out who gets to come back and when. And so there's we have 3 different categories of employees depending on how much they need to be in the office, and it's really changing our work culture. Whereas before we were fairly traditional in our thinking about this and discouraged creative work arrangements, but that's all out the window now. And so now it's a lot of how do we prioritize getting the work done in the best way to get it done, but fully acknowledging that not everybody can be in the building anymore. And so, you know, really having to decide where the best place to do the work is, which is probably how we should have been thinking about it all along. But that is one of those positive things that has come out of this, I think, and maybe not viewed as positive by every single employee based on their personal situation, but I think in general, it will set us off. That's the silver lining of social distancing, by the way.
Yeah, well, I went to one event, I think I told you before, I went to one event where they asked us about our rose and our thorn, and that was for COVID, and it was good for me to think about what was good that came out of this. Not everything was so bad, to redo my perspective here. And maybe that good and bad leads to a question that I did really think was important, especially for the healthcare industry, and that relates to the mental health of your workforce. And so I'd really like to go around and hear from certainly each one of the provider panelists, and Gordy, you're certainly happy to weigh in here too. But if each one of you could really talk about what steps your organization took to address the mental health of your workforce. I do think it's a really important topic, especially for the healthcare industry. So maybe Dr. Hanlon, can I pick on you to start this one?
Sure. So we started, we call them mission partners at OSF, the employees, and we started what's called a mission partner support group. So pastoral care actually started that at Little Company of Mary because we were definitely the most hard hit of the operating units in that system. And so this group meets on Tuesday and Thursday mornings via Zoom, and it is well attended. We also have an online platform called OSF Silver Cloud, and that's to give tools for managing stress and depression. I found that the people who work here really, really appreciate in-person rounding with the administrators. And when I would round in the ICU and in the emergency department, when there was really a heavy COVID presence there, that seemed to be very uplifting. I think that the support of the community was tremendously uplifting. The restaurants in the area that donated food, these schools that had children making pictures for everybody, was tremendous for keeping morale up, because morale, people got pretty beat up, people got pretty tired around about the end of April into mid-May. And I think the support group and the Silver Cloud online, along with the in-person encouragement, made a world of difference for our staff. We had very few people who left. We did have many employees who became sick with COVID, but we really did maintain a very good morale. You talk about the rose and the thorn. I love that term. The good part of COVID was, I think, the acceleration of the switch to virtual medicine, telemedicine, and more digital medicine. But I think also it really got people to appreciate the everyday courage of the person who works on the line in the hospital, the nurses, the respiratory therapists, the EVS workers and the transporters who are really next to these patients many times a day, in the nurse's case, all day long. It's frightening. And what this really showed me was just the strength of these people who do this for the community. I was really moved and touched by our people.
Great, thanks for sharing. Earl, do you want to talk about AMITA's efforts about mental health?
Well, similar in many regards. I mean, tough to follow Dr. Hanlon on that one, but I think that we're obviously very concerned about the physical well-being and the mental well-being of all of our employees. I know with our physicians in particular, we were already facing issues just generally with regard to physician burnout pre-COVID. So, there have been a number of initiatives that were focused on being able to provide access to services for our doctors. And so we do have a program in place that allows for any member of our medical staffs to seek some of the services they might need from a mental health perspective, just to try and keep things in balance and life in balance, and so that's worked well. I know that we're looking at some ways to expand that and make it more effective, but that's kind of a work in progress. The work for our employees, which includes some physicians. I mean, obviously, we did provide access to services, counseling services, and they were accessed. So our statistics are showing that they were very heavily used and accessed. I think one of the things we found, quite frankly, is we rely upon a third-party vendor to provide those services, and I think we found in many cases that our vendors were overwhelmed. And so, the hotline that you were supposed to be able to call and get through immediately, you might have to wait a day, which, so I can't help it from the lawyer perspective. I mean, I know that one of the things we're going to be looking at is, as we're vetting our vendors going forward and doing our due diligence, is making sure that they truly have the capacity to ramp up when we find ourselves in these types of circumstances. But, and I think the most important thing that occurred is we have a relatively new CEO here, and he set the tone fairly early on with the virus, and that we were going to be very, very focused on patient safety. He was very, very good about, on a weekly basis, making sure that there was either a video or newsletter that went out from him, with a very direct message about how important it is that our folks stay safe and that they take care of themselves, and that they do find time when they are away from the job to truly recharge. And I think that was well received. I think that our folks felt that we have a new CEO that really cares about the people that work here and cares about the outcomes that we're getting. So all in all, I think our folks fared well, but this is one of those that I don't, especially in this day and age, I think you have to just keep working to get better and provide greater access to services.
Well, how about Erie's efforts towards mental health for staff?
Yeah, I mean, it's hard. And, I'm not going to say we've cracked the nut here. I think we have found for our clinical staff that they're exhausted. Even just wearing PPE all day, every day is so draining. It's uncomfortable, it's hot, and it's sort of, it makes it impersonal in their interactions with patients. And so, there are very real needs. We have offered our own behavioral health services to our employees, all of our sites, mostly now off-site, but offered those to our employees. We did a lot of things like our development team started some fundraising efforts specifically to support staff. So things like a fundraiser to buy lunches for clinical staff and surprise people by showing up with lunch, catered lunch. And that fundraising, what we found was actually most impactful was fundraising among our employees, where we asked employees, do you want to have $20 taken out of your paycheck this month to support lunches for your colleagues? And it was wildly popular. And sort of, I think everyone was looking for ways to stay connected and looking for ways to support each other. And this felt like a little easy thing to do, but in the end, there were, I wish I had the numbers in front of me, but dozens and dozens of lunches were delivered to our clinical staff at various sites. So some of that, it's small, but morale building in multiple different ways. I think we also found that we needed to help our staff manage their own challenges that were added stressors, like our medical assistants having to figure out how to wash their scrubs every day, the way that how to meet the requirements there. So we bought laundry machines for our clinic site so that they could actually wash their clothes, and we relaxed the dress code requirements just so that we could kind of take things off their plates, other things that might be contributing to their stress, and say, okay, we're going to prioritize here, and can help with the energy you need to actually do the most important stuff.
I mean, those are great, really tangible examples, because I feel like lots of companies and say, we're here for you and we support you and we know that you're stressed, but I think those are really tangible, obvious examples that looking for ways to, relieve the practical stressors in order to make way to get the job done, I think is really important. One question, it's a big question that I really want to end with, and I warned the panelists that I was going to get here, was I really do want to hear from people on the front lines, from providers, about the fundamental changes that you really think are needed with respect to care delivery. And we do want to focus on post-COVID, but so whether you've been thinking about this for 10 years and it was exacerbated, or you had an aha moment, during COVID, I am interested to hear, if you had a magic wand, what is the fundamental change that you really think could make a big difference in the care delivery? Who should I put on the spot? Who wants to volunteer?
People spoke about virtual visits. I think that just goes without saying. I think the payers have to be willing to pay for that. I think it is good on a lot of levels. I think we could be more productive. Patients like it. Certainly during times of epidemic disease, it is better. I think there has to be much better protection against infectious disease on an ongoing, everyday basis. I read recently that there's probably been a couple thousand prevented deaths from flu because of the precautions we've taken with COVID, which is a crazy idea that, we've got a couple more thousand lives that we've saved because we've been better doing things we should do all through the flu season. We've had so much resistance to good hygiene and mask wearing and getting vaccinations during flu season. That just has to change. I think we also have to get patients out of the hospital and do healthcare in the home. Physicians really shouldn't be data gatherers. There is so much data that can be gotten from sensors, from other analyzers. APNs and RNs can bring portable ultrasonic devices, which are not out of this world anymore, into the home. The stethoscope, when you think of it, is a 200-year-old device that really tries to impute structure from sound. So why don't we just go right to the sound? I think there's a lot of things we can do to collect data and have physicians just analyze and act on that. And finally, my pet peeve that came up with COVID was the EMS system in Illinois, which is not set up for a prolonged, geographically dispersed disease, but is really set up for mass casualty. So what happens with these large regions, for example, we're in Region 7, right on the edge of the city. Well, Region 7 goes all the way out to Kankakee and Morris. We are very different areas, but we're treated the same by the EMS system. And therefore, when one hospital has an ICU that's filling up and is running low on ventilators and the other one in the same region is not, there is no authority that really says, move these resources around for better care. You're basically to the mercies of any other hospital anywhere that's willing to take a patient. And that, I think, really has to change in the EMS system.
Those are all great examples, from easily done to more difficult done. Those are great takeaways. Earl, any thoughts?
None as complete as Dr. Hamlin's thoughts, but I do think that one of the things that certainly we've taken away, and I've taken away from this, is how critical it is to have a nimble executive team that can coordinate and move things forward within the organization. I think that by nature we like to study, and it can take an awful long time before some of the things that we think might be best for patient care are actually implemented. And I think that this virus, this pandemic, has forced us all to move at a much more nimble pace to achieve an outcome that's best for the patient. So that's kind of what I'd like to see maintained. I do feel too that there was a spirit of cooperation and collaboration. I mean, it wasn't always perfect amongst competitors within the marketplace, but I do feel like we did all come together and figure out how to work well and play nice in the sandbox, as it were, and do what's best for the community and the patients. So I'm hopeful that we can continue in that same spirit as we move forward.
Yeah, you are not the first executive I've heard describe the nimbleness, and I think sometimes the death by committee or consensus and needing to move faster and sort of apologize later and tell everybody that things are going to change and we need you to adapt and we need you to be flexible and we need you to use common sense and move forward. And so I think some people have found that quite liberating to know that things can get done in a different flow, I think. Nicole.
First of all, I would second that. Coming from a place that is a very consensus-driven culture, lots of collaboration, and that's how we work. We have had to figure out how to move faster and be more decisive. Really focus on the people who are the experts making the specific decisions, and that's in some ways has been healthy for us. I think we'll recalibrate a little. We'll move back a little toward our more comfortable culture, but I do think we've learned a lot from this. I think we've been talking a long time about providing the right care in the right place at the right time. And in some ways, I feel like, at least on the primary care side, we've kind of been dancing around it. And we still believe very much in this medical home model, that we provide a long-term medical home for our patients, and that's really important. But I do think we are moving more in a direction, and I think we will land in a place that really is, some of it's about virtual visits, and do you even have to come in? Sort of care on demand almost, integrating behavioral health and figuring out what's really the core issue here. And if it's depression or anxiety, let's focus on that first. And we can do all that, depending on what your needs are. Maybe your issue is you really need access to healthy food, and maybe you don't need a doctor's appointment. Maybe you need one of our case managers. And we've always done that, but I think there is a flexibility here and a more nimbleness to it that I think is really going to be good for patients. I also think we are moving in the direction of payment models that can support it. And it's accelerated our conversations around value-based care. We have a new contract that I never would have imagined 3 or 4 months ago we would have. And it's made us a little less risk averse here, and realizing that if we want to move toward this model, especially post-emergency payment rules, we're going to have a different way of getting paid by our health plans. And so I actually now feel much more optimistic that we're gonna get there.
Great. Gordy, do you want the last word here? Fundamental change.
Yeah, I think I echo everything that every other panelist has mentioned here. I think, you know, the last comments about being more flexible and agile and nimble as healthcare providers is really key. I think particularly as we see other large, well-capitalized organizations look at the dollars that are available in healthcare and try to drive disruption and change and potentially replace what we see as traditional providers. So I think all that's necessary in terms of decision making. To really move and quickly pivot to where, you know, we think care needs to move. And if that's more value-based care and shifting more of it to the home setting and doing it at a lower cost, we should move to that. I think along with that, just being more in tune with what your consumers want, I think is something that healthcare providers maybe need to embrace a bit more coming out of COVID is, you know, where does the patient want to get its care? And really, I think doing the research to understand your patient base a bit better and kind of what their needs and wants are and adapting your care delivery to meet those. I think is something that's going to be really important moving forward.
I agree. I think that's a good note to end on. We're only, I think, 1 minute over here. So I think we'll end on that. I really want to thank each one of you for your time and your insights, and a special thanks to Kaufman for partnering with us to kick off this series. If anybody is particularly interested in telemedicine, we're hosting another webinar this Thursday at 11:30 Central on telemedicine. And you'll be able to access the recordings from today's webinar as well as the recent NP webinars and register for upcoming programs on our website, nixonpeabody.com. And finally, if you'd like to subscribe for any industry or practice specific mailing lists, we will share a follow-up email and a link to key takeaways from this program as well afterwards. And with that, I think that's all my housekeeping updates, but I really do want to thank each of you for your time, and I appreciate it. Hope you all stay well.
Take care.
Thank you. Appreciate it.